Well, welcome everybody. Thank you for joining us in our monthly webinar series. We're now nearing the end. I think we've just got one more of this in December before the end of the year and the end of our series. So we're now on to chapters 11, 12 and 13. And just as a reminder, I'm sure most people will have been able to join us for some of the earlier webinars, given that we started back in August and we've covered chapters 1 to 11 so far. But we are running the webinar series as the Network for Ecohealth and One Health. And that was because most of our authors for this open access textbook published with CABI were from the NEO network, but then we brought in a wider audience of authors as well who've been able to join us on this project. So the book, Principles of One Health for a Better Planet, did go open access earlier this year in about May. So please do check it out and we can share the links and the QR codes and things, and you should have got that through the invitation for today's event. But carrying on in the vein of the webinars so far, our plan for today is to take 10 minutes to go through the 3 chapters that are up for today's discussion, and then we'll open the floor for a Q&A and a bit of a chat really about some of those principles that are underlying those particular chapters. And I think we've moved into the implementation zone of the book, which is very exciting. So today we're going to be talking about systems thinking for One Health interventions. We're going to talk about the evaluation framework for One Health, which of course is where NEO started. Originally we were the Network for Evaluation of One Health before we cunningly changed the name but kept the acronym. And then finally, Massimo is going to get us onto the economics of how we turn that evaluation into a metric, perhaps, that a lot of our policymakers and perhaps funders will be most familiar with when we're making the case for One Health. So today we have 3 speakers for you. We'll introduce them. I'll let them introduce themselves rather than their chapters when we come to them. But just as a reminder to say that as a network, we are available for people to join from anywhere in the world. At the moment, our membership fees are suspended, but we are going to be bringing in just a small membership fee soon, just to make sure that we can sustain the network and keep some of these activities going, although it is very much, I would say, a volunteer-led organisation with a lot of goodwill put in there. So if you are interested, we have a early careers group as well. We've got Evan Griffith, who leads that group, who's on the call today and who's also our secretary. And we'll be able to point you towards the website. You might be able to see it in the corner and get the right angle of my screen for the website address for NEO. And on that website will be links to all of our outputs, including the original evaluation framework, this open access textbook, but also a Google form for you to fill in any details if you would like to join the network, and we can get back in contact with you over email if you're able to fill that form. Okay, thanks very much then. I shall pass over to our first speaker, Marie.
Thanks, Gabby. So I'm just going to share my slides, which hopefully... Can you see my slides now?
I can see them not in presentation mode yet. There we go, perfect.
Like that. Right. So my name is Marie McIntyre. I'm a Translational Food Safety Fellow at Newcastle University in the UK. So I was the lead author on chapter 11, and as a group, when we started developing the textbook, we were talking about what's missing and what would be useful. And actually, for me personally, what would be useful is simple steps to actually do One Health. So I set out to chart as exhaustive list as I could come up with, to a certain extent, of simple steps and kind of checks to do when you're thinking about how you do One Health. So the aim was to show how to practically design and implement One Health projects. And One Health interventions are multisectoral and transdisciplinary, built on equal partnerships and supported by shared resources and shared language, and therefore shared understanding. And they're then therefore guided by jointly defined measurable outcomes. And so communication is obviously a really important part of this. And we wanted to show that interventions must be holistic and not siloed. And within this chapter, how to achieve getting those non-siloed interventions. So why are interventions changing? There are barriers, disciplinary silos and fragmented funding, as you've probably already heard within the seminar series, unequal resource allocation, power imbalances within those impacted, organisation separation of responsibilities, both within and across organisations, And we had some examples within the chapter where these problems had happened on human-elephant conflict with local communities, forest fires, with ecosystem focus without integrated public health, and UK waterways with fractured responses to contamination. And if you're in the UK, you'll have heard a lot more about that on the news recently. So by taking a systems-based approach to develop a systems understanding, we avoid fragmented short-term fixes. So across these 3 chapters, and I think probably the one before, or possibly one of the ones before, we had some steps in practice. So within chapter 11, this is figure 11.1, and you'll probably have seen it before. And within this chapter, we're focused on this kind of area of the figure. So we talked within the chapter about defining your One Health problem clearly and setting boundaries for that problem, identifying stakeholders and mapping who affects and is affected by the problem, conceptualizing the pathways to particular outcomes. And there were various methods and exercises to enable that to happen and to enable a group of people to think about those pathways, but also to chart and prioritize the importance of different pathways. I've put from an ecological perspective because the next speaker will be covering the kind of more economic considerations. And we also talked about how to develop intervention options, as I say, to understand from an ecological perspective which options might be the most important and which ones might be the most useful, including thinking about communication, engagement, and to facilitate working. So the key points were about a very much iterative and participatory process right the way throughout the project, with communication-driven approaches and this iterative feedback at each stage. So we put systems thinking into practice with a nice example of Mycobacterium tuberculosis and bovis, which had the mapping of causal pathways from outcomes to interventions. We talked about anticipating feedback loops and looking at the stability of the system when you're looking at interventions and which interventions are the most appropriate. We talked about thinking about and recognising trade-offs in the decisions that you make, and being cognizant that improving one aspect of a One Health system could harm another aspect. So you needed to balance and really prioritise and provide just evidence-based justification for which trade-offs were the path of least resistance. We thought about balance via joint decision-making, equity, and having flexibility in that decision-making, again, within that process to really understand which part of the problem was the most important to solve first, and actually who within the group of involved were the ones who needed that resource, in terms of first, as opposed to thinking about what they needed later on. And systems thinking ensures that interventions become sustainable, and adaptive, rather than trying to solve a problem in a siloed perspective. Even if you can't solve everything all of the time, by being aware of the different perspectives and the different problems for different stakeholders, you can solve part of the problem and then perhaps feedback and come to a point at which, in another reiteration, you can help with another aspect of the issue. So the essentials for implementation were about having a strong communication plan which you've tailored to the suitable audience, having active and meaningful and, as I say, iterative stakeholder engagement, undertaking knowledge sharing across disciplines and communities and setting that up from the start of the project, and keeping that dialogue going throughout the course of the activities, and creating and developing and creating and continuously updating learning around the process that you're developing and that you're implementing. So the communication and the engagement are as critical as the technical design. You can make something which is technically very good, but then if you don't communicate it properly, it all falls apart. So we had a really nice applied example of sea otters and toxoplasma, courtesy of Deb Thompson, at One Health lessons, talking about stray cats and toxoplasma runoff and sea otter deaths and kelp decline, followed by coastal erosion, and then human and economic impacts. We talked about, within this example, engineers and politicians, marine biologists, veterinarians, animal welfare groups, and local communities, all as stakeholders within the problem. And then we had the lessons from that, where each group frames the problem differently according to their needs and their perspectives to help create the most sensible and sustainable interventions and to help facilitate the building of the coalition to kind of sort that problem out, and also create shared ownership in the outcomes for that to make sure that they're maintained going forward once they have been implemented. So this is all about integrating the diverse perspectives on the One Health problem in order to create that long-term outlook for solving it. So the learning outcomes for the chapter were about identifying feasible interventions, describing the participatory challenges and also their solutions, recognising the educational and networking opportunities, but also needs when developing an understanding of the problem and an understanding of what the potential interventions might be. And the idea that doing One Health is as much about process as it is about outcome, because by ensuring you have a strong and well communicated process, you're going to increase the potential utility of the outcomes. So doing One Health means systems thinking, it means participatory design, it means effective and clear communication and continuous iterative reflection and adaptation. And they're most likely to succeed when those tiles are on the table. And I think that's my last slide. Thank you.
Thanks very much, Marie. Yeah, absolutely. A lot of things resonating there that I'm sure we'll be able to come back to in the discussion. And it's nice to really think about, the practicalities of how we implement One Health as an approach. We've spent a lot of time talking about why it's important and what it is, but how do we actually get started? So that's a great way to kick us off. And I think perhaps the evaluation talk that's coming next from Ilias will also help us to kind of get into that little space a little bit more and think about the practicalities of how we actually do One Health. So I'll hand over to Ilias if you want to share your screen. Thanks.
Yeah. So let me know if you see the full screen.
Correct. Yes, looking good.
Yeah. So I don't know if, sorry, I think I have to move this. Yeah. So as I kick off, let's say, my part of the presentation, I would say one thing is to have and One Health approach and One Health initiative, and the other thing is to sustain, and another thing also is how to prove and how to show that it works. So then this chapter, I hope it will provide the tools to answer such questions. So does it work? Can we prove it? And I will start acknowledging my co-authors that all helped form this chapter. And of course, there's a lot of background and preparatory work and previous work that was done for the needs of NEO for this. So I have to credit also NEO for that. So why evaluate One Health? Is it necessary? So evaluation is necessary because it ensures the effectiveness and efficiency. So it isn't just a box ticking exercise. So it gives a little bit the evidence needed to secure, name it future funding, name it influence, name it legislation, and of course support. So it also allows for learning and adaptation, and it fosters continuous learning. Yeah. So if something isn't working, we need to know why. So the main challenge here is that One Health is not that easy, and One Health is inherently complicated. And of course, all the actions in the animal sector might have economic impacts on humans or ecologic impacts on the environment. And that means that the traditional evaluation strategies is not, let's say, the one guarantee for success. We should not, and we must not miss cross-sectoral links. So that leads us to the evaluation framework. And for this, our starting point, we have the NEO evaluation framework, which I will not show you the full because it's not an easy, we would need I think 3 meetings for this, but a simplified version is shown here. We need to remember that the evaluation is not the end point of the cycle, it is a cycle. So it has also the reflection of the system, and we do aim to have a continuity in it. And so the steps that we have the step of system definition, we have the system boundaries defined. Then we move to the creation, like, of the theory of change, which on its own, I would say it was covered in the previous webinar. And of course, we have the element of assessment of One Healthness, which is the process of having the work together, and measuring the actual outcomes. So the impact is also a step. And finally, one step as well is to compare the process to the outcomes to see if this collaboration actually led or not to better results. So it's a dynamic process. And how to see this process and how do we do it, we need to map the pathway, and there's not better way to do it than using theory of change. And because the theory of change describes how and why a change is expected to occur. So to show this, and in the chapter, if you will see that we have used the vaccination example. And for that, we have inputs, name like vaccines or stuff, and then they lead to outputs. For instance, here in our example is the vaccinated population. And this, from the outputs, we also have the outcomes. After doing the vaccination, we have the reduced morbidity. And of course, we also have the long-term impacts, like better productivity, or even going about implications for trade and so forth. So it's something in One Health context, we do look out for the intended outcomes, but also we do look for unintended outcomes. So for instance, let's say if you do a health intervention, and would this benefit or harm the local economy, for instance. So having this theory of change helps us mapping this intervention out. So beyond the outcomes, we have assessing One Healthness, the process. So here, this assessing, the measuring the process, we name it as One Healthness. And that was comprised and I would say used heavily in the NEO framework again. And the NEO framework has had 6 aspects of One Healthness defining. We have the thinking aspects with the systems thinking coverage, is going over the understanding the whole system if we get it correctly, is the planning aspect. And we have the working, the sharing aspect. For instance, sharing aspect is important if we have open access, and is it like shared with the actors? And of course, for learning, opportunities to adapt the system. Do we have, how, and also how it is organized. So in how organized, we are more like reflective on how effective the structure of the team was, how effective was the leadership done. So we do all these steps because we aim to score to see how integrated the initiative is. And in the same approach with Mari at the previous presentation, we also have an applied example there, and we have a real-world example from Portugal, evaluating a surveillance system for teniasis and kysticercosis. So there they use the NEO framework, and the result, as you can see, and if you are familiar with the NEO framework, the result is depicted through a spider diagram. And we have the different components, and there you see where they score highly. For instance, here it's on the thinking and the working in the left side. And that probably indicates that there was a good scientific collaboration. And then you see weaker on the sharing and organization, which is on the right side. So there are elements to know exactly where they need to improve. So we talk about the NEO, and we talked a lot, but it's not the only tool. There are more than 70 tools, standardized tools available. And here, for example, we have the One Health EpiCup. It's a great tool as well, and it's excellent specifically, I would say, for surveillance capacities. And there we had a nice figure provided by a publication did by Mora and colleagues. And there we see an evaluation of DANMAP. DANMAP is a pioneering it's a pivotal, and the DAN is antimicrobial resistance program and usage. So there they evaluated the capacities in surveillance, and you see they were able to see where they score high, and they have a lot of, let's say, really well covered areas. But then they were able to see where they can have a better, let's say, better environmental data integration for their tool. So here the lesson is to choose a tool that fits your specific goal. There are many tools, and there are limitations and benefits using each one. So as learning outcomes, what we have here, that we have that by understanding these steps, you should be able to apply standardized methodologies, and also to be more familiarized with the methodologies like theory of change, and also to recognize that we have a lot of tools, and not a tool is not, let's say, the solution for all cases. There are specificities, there are limitations, there are strengths. And finally is to make sure that you select the right design for your context. So as a take-home message, we have that evaluation provides evidence for decision-making and funding, and that's really important. And finally, I close with a conclusion that talking about One Health evaluations means asking, did the initiative improve the health outcomes? How effective was the collaboration? Is the initiative implemented as planned? And of course, as a small lead to the next presenter, is there a return of investment economic? And with this, thank you very much.
Great, thanks very much, Liz. Yes, good to revisit the spider diagrams of days before. I think that is a really important, I think, the discussion of a theory of change as well. It's something that I've come to as a tool, as just a thinking process. And I think you mentioned that the process, Anne-Marie also mentioned that the process is as important in One Health as the outcomes. And I really think that these ways of thinking about things, whether that's the One Health project cycle that Marie was mentioning, or the evaluation cycle that you're speaking about, the way of thinking through these things and what it is that we're trying to achieve, and exactly how it is that we are going to have those impacts, both intended and also the unintended consequences or interconnections that we might discover in that system, is a really useful thing to be thinking about, and exactly where the kind of power of One Health thinking comes into to achieving impacts that are more sustainable and more impactful. So thank you very much for that. I'm sure there'll be some questions for you afterwards, but if we want to turn now to Massimo, who's going to take us from the evaluation framework into the more economic detail. Perfect. Yeah. If you want to go full screen, and then it's all the floor is all yours.
I try to go to full screen, hoping that you can. Could you see my full screen?
Yes, that's perfect. Yeah. Thanks, Massimo.
Perfect, thank you. So the aims of the economic evaluation chapter on One Health interventions has three main aims: to set the principle of economic evaluation of One Health initiatives, and conceptualize One Health economic evaluations, and use the evaluation results for decision-making on One Health investment. Key questions concern the reason why economic evaluation are important for One Health, how to conceptualize the economic evaluations of One Health, how the main economic evaluation methods quantify the value of One Health intervention, how to address uncertainty to provide the robust support to decision-making. This is an important point because each evaluation also simply technical evaluation are, for the most, only hypotheses of future events. So, and all evaluation are affected by uncertainty. And this is especially true for economics that deal with changing prices, etc. And how to evaluate one else, consider its multi-level dimension beyond the monetary paradigm, and how to approach financing and budgeting. Not all this will be treated in this short presentation, but we try to give the basics for this. So main barriers to the economic evaluation, why economic evaluations of one else are a real challenge because of complexity. One else outcomes are impacts and impacts are on different sectors, human, animal, and environmental health and welfare. And we have multi-sectoral implications in human activities. For example, we have implications in human and veterinary medicine, agriculture, food security and safety, economy and trade, social and gender issues also, and wildlife and the environment, and many others you can find if you analyze. And there are also a wide presence of non-market goods and services. And in consequence of this, there are intangible and costs and intangible benefits. That means that we have no prices for most of the goods and most of the services that are produced in One Health initiatives. An example here, maybe we can see this example for setting a surveillance and control system against brucellosis. You can see that we have impacts on animal health with the reduction of brucellosis prevalence in livestock, improved animal welfare because of health state, and achievement of the status of free area for the interested area. In agriculture, we can speak of increased productivity of dairy farming, so more money for farmers, improved milk quality for the milk supply chain, and increased potential for animal product trade, because we have barriers to trade from areas that are affected by this disease. Effects on wildlife, decrease the risk of transmission between wild and domestic animals and humans, and the effects on human health with decreased brucellosis cases in humans, reduced cost for health care services and for households also, decrease in productivity losses for human cases, people that cannot go to work because of the sickness, and the achievement of eradication in the population concerned. And if we see at the One Health project cycle, the economic evaluations are in all phases. In the planning, we have ex-ante evaluations that are functional to plan the intervention, but mostly to selecting the intervention alternatives. And it is a big support to decision making. And interim evaluations, so during the project implementation, when the intervention is going, we can check if the intervention is achieving its objective within the expected cost and benefit framework, and support decisions on adjustments of the measure of the intervention. And after the intervention, we have ex-post evaluations that calculates the economic values. That is to say, the benefits and the costs generated by the intervention, including the unexpected costs and outcomes. Here we have an example the practice of economic evaluation, we have again these two alternatives for brucellosis surveillance. One system is based on bulk milk tests in all farms twice a year, and the intervention, the alternative is an intervention based, is a surveillance based on brucellosis serological tests in all farms that are done once in 3 years. So these are the two alternatives. Each alternative implies different uses of resources that are related to cost, and they generate consequences that are also object of this evaluation. So the economic evaluation is this comparison of costs and consequences of the two interventions. And after the evaluation, we have also these sensitivity analysis that consist to recalculate the results, making different hypotheses in technical parameters and prices because of variabilities of this and uncertainties of technical results. And there are two types of economic evaluation. It depends on the alternative examined and if we have evaluation of both costs and consequences. When we have only one intervention, we have a description of results, or description of cost, and the results. But and if we have two or more alternative interventions, we have evaluation of effectiveness and cost analysis, for example. And all these are partial evaluation. We have full evaluation when we have more than one alternative. So more alternative, and the consequence and costs are examined. So, and in this case, we have cost minimization analysis when the effects are the same, and the solution with the less cost is preferred. We have cost effectiveness analysis and cost utility analysis when the effects are measured by indicators of life quality and health, and cost benefit analysis when all parameters, costs and benefits are evaluated in monetary terms. These last four are the full economic evaluations. And some essentials of economic evaluations. Cost, in economic evaluation, costs are the resources used for an intervention, and or also decreases in the state of well-being of an individual. Benefits are the contrary, are increases in the state of well-being of individuals that are given by satisfactions of individual needs. Market prices are indicators of the resource availability and competition for their alternative use. So they are sort of proxies for the evaluation to attribute values to resource used. And so in this case, we speak of tangible costs and benefits when we can directly assess these elements through market prices. For goods and services that cannot be directly assessed through market prices, we speak of intangible costs and benefits. And these are evaluated by assessing the willingness to pay of individuals for these assets. When we have to deal with the resources that do not exhaust their functionality with use, like buildings, machinery, equipments, tools, etc., we have to calculate depreciations. And when we assume the public interest of one else intervention, we have to adopt a social rate time social rate of time preference. This means that values considering a long times are different. So values change a long time, and the same amount of money, for example, has different value. Is this considered now or in 10 years? And so, and this needs the operation of discounting. And discount has consequences on the evaluation of environmental goods and the evaluation of health. Because so you have if you have a positive effect on the environment in 10 years, this will be lesser if evaluated now, and vice versa. So these are also implications in the ethics of the evaluation, for example, to consider the impact on future generations and etc. And lastly, the point of view of the evaluation, a welfarist approach considers the interest of the whole society, or the whole community, but when we consider an extra welfarist approach, we consider only benefit, costs and gains or savings for the organizations that manage the intervention. Sorry. So we applied examples on all those aspects in our chapter, in this chapter, and especially we had a whole cost-benefit of analysis of 2 alternative brucellosis surveillance systems. And also consider application of discounting, calculation of depreciation, and different types of full economic evaluations as we have seen, and the respective evaluation parameters like the net present value for the cost-benefit analysis, and the incremental effectiveness ratio for cost utility and cost effectiveness analysis, and the different metrics used like dailies and Cayley's, and application of deterministic and probabilistic sensitivity analysis. Learning outcomes are to understand the basic principle of economic evaluation of One Health initiatives, know what to consider when conceptualizing One Health economic evaluation, and discuss the economic evaluation results and how to use them for decision-making on One Health investments. And to conclude, I would like to remember an old definition, an old working definition of One Health, but is always worse. That this says that any added value in terms of health of humans and animals, financial savings, or environmental service, which is achievable by the cooperation of human and veterinary medicine, when compared to the 2 medicines working alone. This is One Health according to this old definition. Thank you very much.
Thank you, Massimo. Yeah, I think that's a really nice conclusion in that we've gone from thinking about how the project might be implemented and how it might be evaluated, but also how to make the case. Like, what do we do with the results of that evaluation, and how do we use them in decision making, whether that's for with policymakers or when we're applying to funders and so on and so forth, and the difficulties of the demands maybe of it always being an economic metric, which is expected in a lot of these circumstances. And I know we've got one of our co-founders from NEO, Barbara, on the line as well, who helps to run the community of practice for the return on investment of One Health, which I think is hosted by FAO. And that's certainly an ongoing and interesting conversation there around how we make that case. And I think that speaks very nicely to Jakob Zinstag's old definition there, which was only covering the vets and the medics at that point back in the day, which we now know is certainly expanded into a more broad definition, but still a valuable point around how we demonstrate the added value. Why is it worth doing the One Health, taking a One Health approach over and above taking any other type of approach, a siloed approach, for example? And I think these 3 talks have really helped us to speak to that.